So welcome everyone to our 5th network session, the second of today. This session is all around accessing healthcare for street connected children, and we'll have presentations from both Shona and followed by Debapriya and Naresh from CINI. Shona will be speaking about a research project that she's leading, looking into street connected children's access to healthcare alongside Street Child United and CSC. And following Shona, Debapriya and Naresh will speak on behalf of CINI, which is a frontline organisation that's been supporting street-connected children and young people in Calcutta since 1989 through their local network and in partnership with the local state and their trained street champions. They're implementing a strategy which includes providing access to healthcare, which they're going to be telling us more about shortly. So I'll just share the presentation. Hopefully you can see that. I can't see anyone else anymore. So if there's any emergencies, somebody come online and say it out loud because I can't see you. So as I say, today we're going to be to services. So we will be holding a question and answer session at the end. We will go through our colleagues from CINI speak first, both of them, and then we'll have questions at the end. So please add questions into the chat as we go along, and then we can pick those up at the end of the session. Equally, if you'd rather raise your hand when we get to that Q&A session, that's absolutely fine. I know some people have already started, but please feel free to use the chat box to introduce yourself to the other participants, or if you have any questions or any issues, there's lots of CSC staff on the call who can respond to those for you. If you want to tweet about any of the sessions, we're using the hashtag CSC Network Forum 2022. And also to let you know that this session is being recorded. So if you're not comfortable being recorded, either kind of switch off cameras and just listen in, or to leave the session. The recording will be made available to all network members once the forum is concluded. There's no breakout session, so the whole session will be online for you to refer back to. So no need to worry if you can't take notes fast enough or anything like that. So at this point, I'm handing over to Shona. Shona, here's your presentation. Please feel free to just say next slide when you're ready for me to move on. But we're all really excited to hear about your research.
Thank you, Lauren. Hi, everyone. You can go on to the next slide, Lauren, please. So I am going to talk about the initial findings of some ongoing research that I'm doing on behalf of Street Child United and CSC. We're looking into the health concerns, access to healthcare, and barriers to accessing healthcare for children in street situations. So first, I'm going to talk you through the methods that we've been using briefly, and then going into some of our findings about the health problems that children in street situations face, how they respond when they are ill or injured, and the barriers that prevent them from accessing the care that they need. Next slide, please, Lauren. So, sorry, I'm also full of the cold, so excuse me if I have to stop and cough. So we started by looking into the existing literature on the topic of street-connected children's access to healthcare. And that let us identify the key themes around which we wanted to structure the data collection and find out what gaps we wanted to fill. One of the really interesting questions to come out of this literature review was around the extent to which children in street situations access to healthcare differs from other children who are in the same context and from similarly economically poor families, but who have not formed a connection with the street. So that's something we're still looking into. Following the literature review, we developed an online survey that we sent out to the adults from the organisations who are participating in the Street Child World Cup, as well as a selection of CSC's network members, many of whom I can see here in the chat. So hello, nice to meet you again. And following the survey, I conducted remote interviews with some of those organisations before travelling to Doha in Qatar last month, where I conducted a questionnaire with 34 of the participating adolescents, a few more of the team leaders, and some of the young leaders who are young people who've previously participated as children but who are now over 18. The data from the World Cup itself is still at the stage of being transcribed and analysed. So the findings that I'm presenting here today are from the adults rather than the children. Thank you, Lauren. So when we're talking about the survey that was done remotely, we had 28 different organisations who work directly with children in street situations respond. And they're from 20 different countries in Asia, Africa, and the Americas. Some of the organisations only work with girls, others only with boys, some with children of other gender identities, but most work with a combination of these gender groups. And as you can see, the age range that they work with also varies quite significantly, as you can see there. Next slide, please, Lauren. So when we asked about the health concerns of children in street situations, we found that the results really confirmed a lot of what we knew from the literature and from our experience in the sector. We can see that the various forms of violence that children in street situations are commonly subjected to remains a major concern, along with sexual and reproductive health. These two things may, of course, be in part related because of the high rates of experiences of sexual violence and sexual exploitation faced by this group. And both of these categories were identified by 82% of the survey respondents as one of the main concerns. Following that, substance use and addiction was reported by 71% of the respondents. And we know that this issue is closely related to mental health, which 68% of the respondents identified as a main concern. But when we combine these results with the qualitative data from the interviews, we can see that two concerns come out particularly strongly. The first is menstrual hygiene and reproductive health, and the other was mental health. And that's really interesting because, of course, both of those issues have gained prominence on health agendas around the world, much more widely than street-connected children. So it's interesting to see those come up there too. Next slide, please. Something else that we asked about was whether there are differences between the health concerns of children in street situations of different genders. And as you can see here, there's a strong feeling that there are gender differences for girls in particular facing specific concerns. About half said that there are specific concerns for boys, and there was much less knowledge around children of other gender identities. Next slide, please. The idea that girls face specific concerns, of course, makes sense when we consider the focus on menstrual health and hygiene. But organisations are also reporting that girls are more commonly exposed to sexual violence and exploitation, while boys may be facing other forms of physical violence and more likely to turn to substance use. But we should add a caveat here, of course, to point out that boys can also be victim to sexual violence, and we know that boys are less likely to report sexual violence due to the stigma that exists in many societies. But in any case, whatever the form of violence, violence as well as the different traumas that children in this situation are often exposed to can lead to or exacerbate mental health issues. So all of these concerns are really connected together. Next slide, please, Lauren. So if we move on now from the health concerns to the care-seeking behaviours, or what children do when they are ill or injured. The literature suggests that we will see this group only seeking medical care when a situation is an emergency. And as we can see from our data, for minor issues, children may most likely be expected to turn to NGOs, public clinics, or pharmacies, while for more serious issues, they may go to a hospital or to an NGO. Now, here it's really important to recognise that our sample is skewed, both with the data that we've got from the adults in the organisations and from the children in the World Cup themselves, because they're necessarily talking about children who are already in contact with an organisation. And those children may well be in a better position than children in street situations who have not formed this supportive relationship with an NGO or organisation. But nevertheless, what is perhaps most interesting here is that although hospital is the most common response selected by organisations for what a child might do with a serious concern, almost 30% did not select the hospital as somewhere children would go with a serious health issue. So that's something that we wanted to look further into. Next slide, please, Lauren. Excuse me. So another interesting question is this idea of whether children in street situations behave differently when they have a health concern from others in the community who are of similar economic status but not street connected. And as we can see from the survey results, the results of the survey were split quite evenly. So what we understand from this is that the tendency to only seek medical attention in an emergency may be similar, but as we're going to go on to discuss now, some of the barriers that prevent children in street situations from accessing care when they want it are specific to that group. Next slide, please. So I'm going to introduce 4 of the main barriers that we've identified from the research. The first 3 came out of the literature and were confirmed by the survey, but the final one was not. This was something that's come out of the interview. So that is something, a new finding that we can add to what was already known. Next slide, please, Lauren. The first barrier is cost. This was the most commonly identified barrier in the survey, which corresponds with what we knew from the literature and from experience. But cost is not considered to be a barrier in all contexts that we're looking at. 71% of the survey respondents thought it was a barrier for children accessing healthcare. And that makes sense when we consider how many different healthcare systems there are in place across the 20 different countries that we've got data from. In some places, all healthcare comes at cost at the point of use, but in the majority, there's a parallel private and public system where at least some services are free at the point of use. So when it comes to cost, there are multiple different factors in play. There's the immediate effect of having to pay for services. That's obvious. We know from our experience in the sector that even when a cost sounds minimal to most people, it can be insurmountable for those who survive on what they are able to earn in the informal economy every day. And knowing that they cannot afford treatment can put people off seeking medical attention at all. But that means that cost as a barrier to access is not exclusive to children in street situations, but is shared by many others of similar economic status. But actually, it's more complicated than that, because even in contexts where there are free services available, the free services might be dependent on the patient having health insurance or being enrolled in a national insurance system or public healthcare system. And that in turn poses problems for children in street situations, because that requires them to have ID. Next slide, please. So we know that in many contexts, it is common for children who are on the streets to not have their legal identity documents, either because their births were not registered at all, or because they have become physically separated from their documents if they did exist at some point. And that means that in situations where ID is required to access healthcare, either at the point of use or to enroll in a system or to keep track of their medical records, children in street situations may not be able to meet this requirement. But compared to cost, this was seen as a barrier by fewer of the respondents in the survey. 39% of the sample identified it as such. But we have also been able to see that it's not as black and white as having to show ID or not, because in some situations where ID is officially required, in practice, children may not be asked to show any documents, or else where they may still be able to access emergency care without their ID. We've also heard of some workarounds, such as the first quote there, which is an example from Indonesia, where the organisation is able to apply for an exemption from social services. That's not ideal because it slows down access to healthcare while they wait for the exemption to come through. And also because, of course, as we mentioned earlier, that only works for children who have that connection to an organisation. Next slide, please. So the third factor that I've been looking at is discrimination. Those of us who work in the sector are very well aware that children in street situations routinely experience discrimination in their daily lives due to stigma and this idea that they are somehow out of place on the streets. And existing studies suggested that this discrimination can also be seen in healthcare settings. 68% of our survey respondents agreed that this was a factor. But before we say more about discrimination, we should recognise that, as several of those who were interviewed suggested, children might not always report the discrimination that they encounter. So this data, it's important to recognise, is really based on the adults' perceptions of their experiences. And once I've analysed the children's data, we'll have more to say about that. But for the moment, what we can see is that many of the respondents believe that children in street situations are discriminated against by healthcare workers. But it seems that this discrimination is not always on the basis of their being in street situations per se. They may be discriminated against because of other factors. So, for example, some talked about children being discriminated against because they are visibly poor, but it might not be obvious that they're in street situations. Healthcare staff assume that they're unable to pay, but they don't know that they're connected to the street. Discrimination can also be based on their ethnic group, their sexual orientation, their caste, their gender identity. And these are factors which might correlate to the reasons that they are in street situations in many contexts, but which apply to a much wider segment of the population. But in other cases, we start to see the stigma and discrimination that children face being more connected to the fact of them being in street situations. For example, healthcare workers may decline to treat them based on their levels of hygiene or the cleanliness of their clothes, or may treat them unkindly based on the perception that their health concerns are in some way deviant. And that might particularly be the case when it comes to pregnancy or sexually transmitted infections or issues connected to substance use. And finally, another factor that causes discrimination is that children may not be accompanied by an adult or guardian. Next slide, please. So the issue of being an unaccompanied child is more commonly specific to the group of children in street situations than others of similar economic status. Of course, we know that some children are on the streets with their families, and many other children in street situations do live at home with their adult family members and only spend some time in the days on the street. So we can certainly say that this does not apply to all children in street situations, but it does appear to differentiate some children in street situations from other children of the same background who do not rely on the streets. And what came out in interviews was that in some contexts, children seeking health services without an adult will be turned away, either because that's an official policy or because the healthcare staff just do not know what to do or how to treat an unaccompanied child. In some contexts, when a patient has to stay in hospital, it's expected that family members will be the ones providing food for them rather than that being done by the hospital. So without an adult prepared to do that, children may not be treated. And having an adult caregiver can also make it easier for children to understand the system and to know which service they should go to in order to seek treatment in the first place. What this really emphasises is the important role that the organisations that we interviewed and others in the sector, like many of you here today, the role that they can play in facilitating children's access to healthcare, as they are able to take on the role of accompanying adult and make sure that the children using their services are able to find and access the treatment that they need. But of course, as I've reiterated a couple of times, it's not all children in street situations who are connected to the NGOs, implying that many are still left to fend for themselves. Next slide, please, Lauren. So that is our findings so far. In terms of the next steps, as I mentioned, I'm still transcribing the interviews that we've done with children during the World Cup. And once I finish that, I'll be combining the data sets for further analysis, and then writing up a report that we hope to publish in an academic journal at some point later this year or early next year. I hope you will all get to read it then. Thank you very much for listening.
Thank you so much, Shona. That's so interesting to reflect on both the main issues and also some of those barriers to access that I'm sure are so familiar to lots of the people we have in the group here. And it'll be really interesting, of course, to see how the children's reflections from the interviews at the World Cup play into what you've spoken around already, confirming or challenging any of that. So thank you. Like I've said, if you have any questions for Shona, pop them in the chat and we'll get to them once we've had our next presentation from CINI. So Debapriya, over to you when you're ready.
Thanks, Lauren and Shona. Great presentation, because you will find in the presentation that we will show that a lot of the findings are really like at par with the experiences that we have in working with street connected children. So what I will be sharing today is CINI's work in that we have been conducting for inclusion of street connected children into urban development programs. Currently in those working in urban sector, in the urban development, we are very familiar with the terms child friendly cities and smart city initiatives. So CINI works for including and participation of street connected children into these initiatives. And I will be focusing upon the inclusion of street connected children into the mother and child healthcare system. But before going into the presentation, I would request Lauren to play a message from one of our very own street champions, one of the peer leaders from the street communities.
Sure, I'll do that now. I'm just going to reshare because I'm not sure I ticked on share sound. So let me just get back to it. Let me know if the sound doesn't come out. It should do.
Sure.
Hello, I'm Ishika. Currently, I'm collecting evidences on the problems faced by my street connected peers, and I'm helping them to take informed choices about their sexual and reproductive health, thus advancing SDG 3, good health and well-being. I'm glad that my voice can reach out to so many of you, and I'm speaking on behalf of millions of children whose voices are unheard. Street connected children are never considered to be a part of the same community people as others who have their roof over their heads. We are often invisible to those around us because we move from one place to another. This movement on which our life depends upon actually creates a barrier to our entitlement because entitlement are only available to those who stay in a fixed place. Goals such as no poverty, zero hunger, good health and well-being, and reduce inequalities remains unfulfilled because we cannot get the schemes and the services that are actually said to be made for us. We need all of you to think how we can access our entitlement even when we move from one place to another. I am urging the world leaders to come up with a solution so that we can access food, healthcare, and shelters from anywhere in my country. Only then we can claim that we have reduced inequalities in our world.
Thanks, Lauren. So that was a message from one of the peer leaders that we work with to the UN's Secretary General, the Special Representative of the Secretary General on the 46th Human Rights Council. So I will go forward with the background. So Asia is one such continent which has been urbanizing very rapidly. And according to the ADB as well, Asia is one of those continents where like half of the world's mega cities are concentrated. And India is like the second most populous countries in the world. And what could be the result? The obvious result is like unplanned urbanization, as a result of which the homeless population is like growing very fast. And in India, the movement from the rural to urban areas is increasing with time. And as a result of this, the children in street situations, they face a lot of climate crisis while they are in the rural areas, and then they have to shift to the urban areas where there is a lot of scarcity of resources, and they have to settle down on the streets. So CINI, what CINI does is CINI aims to build child-friendly communities and child-friendly cities, obviously. And we try to ensure the rights of survival, development, participation, and protection of all children, including children in street situations. And we turn rights into developmental practices through the CINI method. So what is CINI method? So we will see that in the next slide. Thank you. So CINI method hinges upon the philosophies that we all are very much accustomed with, the human rights principles, the CRC, the UNCRC and the UNGC 21. And those are like the most important for the children in street situations because they are the most excluded population, and the accountability of duty bearers, as we all know, and perhaps we have all experienced while working with street connected children and duty bearers. The accountability is the lowest when it comes to street connected children. And the participation and inclusion in public policies as well as social security schemes and service planning and everything is very much lower when it comes to street connected children. Next slide, please. So CINI has been working with street connected children since 1989 when the UNCIC came into place. So so many years of working with street connected children, we have identified a few trends or characteristics that you might say while working with street connected children. And as we all see while working with them, the principal characteristics are, as Shona has also pointed out, a certain hesitancy towards uptake of services, lack of services, homelessness, infrequent mobility, and basically restricted access to a lot of services, including healthcare. And the root causes that we have identified while working with them is that the lack of birth registration as well as legal identities, which is actually a cause behind the lack of services, lack of access to services. And as a result of these lack of services, the right to development gets challenged, which is why they do not get access to school admissions and other access to livelihoods as well. And a lot of these families are actually women-led, and these women have zero access to livelihoods. And there is also a lot of discrimination, as Shona pointed out, that they face while accessing services. So that is why, perhaps, that is why the accessibility of service is so low. So what we do in order to address these issues is we train the children from the street communities. We train peer leaders from the street communities as street champions. The street champions are our favorite topic. So the street champions are representatives from the street children themselves, who are actually democratically elected from the street connected children's groups on the basis of some pre-decided characteristics that the children themselves decide. So on the basis of that selection, we train the street champions on research, advocacy, and then on since the year 2019, we have conducted a participatory action research with 30 street champions. So what they did is they went out to their peers and they conducted a research on the vulnerabilities they face and the gaps in the services that they have available for them. We will come to that later. And on the basis of the evidences that they collect from those participatory research, they participate in advocacy platforms. CINI facilitates the street champions in participating in local as well as international advocacy platforms. For example, there are like local administrative committees where children and duty bearers sit together and discuss about the issues faced by children and come up with solutions. So street champions participate in that, as well as in the UN's Human Rights Council. Street connected children take the issues that they face and demand for changes. And one of our core strategies is referral and linkage mechanisms and sustainable ones. So the street champions identify their peers or family members who do not have access to services or legal identity proofs, and since they're well acquainted with the local duty bearers, they take those peers or family members and refer and link them with the services that they need, which is as a result of which the outputs that are stated here, that is inclusion into services and policies related to education, protection, health, nutrition, as well as environmental policies, we try to ensure that. And the process of ensuring those outputs are hinged upon three pillars mainly, that is participation of street connected children in local as well as policy level advocacy platforms, and accountability of duty bearers, as I said, we regularly conduct interfaces among street connected children and service providers at local as well as international levels, so that there is an exchange of issues faced by children, as well as a joint discussion about the possible solutions that can be brought about. And we also always promote multi-sectoral convergence. Like, for example, the platform that I just spoke about of service providers and children coming together, it is a convergent platform where service providers like frontline as well as policymakers who design services in terms of education, protection, health, and nutrition, they come together and in a convergent way, they discuss with the children about the issues and the possible solutions. And the outcomes that we have been able to achieve is street connected children are now able to take informed decision about the entitlements that they have in terms of education, protection, health, and nutrition. And thus they have an increased access to service because they're well informed about the services that they're entitled to and where they can get them. And also about the discrimination that they face, we have been able to increase the responsiveness of the duty bearers, thus decreasing the experiences of hesitancy or discrimination. And this has been brought about by regular dialogues and interfaces among the duty bearers and the street champions. So the ultimate goal is always about helping street connected children to participate in urban development programs. Next slide, please. So as I mentioned, since the year 2019 to 2021, we have trained 30 street champions on research and advocacy. And with Street Invest, now CSC, we have been able to develop a research training pack that is specially designed to train street connected children on participatory research. And after training the street champions, those 30 amazing young people, they went out to their peers and conducted rapid surveys with 450 of their peers about the vulnerabilities that they face and the gaps in the services that are available to them. So from that particular research, we have been able to derive findings in terms of safety, participation, health, and well-being of the children. And in this particular slide, we have mentioned about the trends in the findings related to health. So as you can see in the slide, there is a high vulnerability in terms of health conditions, especially in terms of malaria, or fever, cough, skin disease, sexual and reproductive health issues, menstrual hygiene, due to living or working on the streets. And we have also observed a marked lack of information about the available services and where or how the services can be availed. And the discrimination is also observed to be more than a quarter of the street connected children reported of being discriminated against while they access the health services. And we also observed risky practices that came out from the focus group discussions in terms of sexual and reproductive health rights. And most importantly, we also found out a stark presence of invisibility of street connected children from the perspective of the service providers, because in terms of policy planning or service allocation, we found out that the service providers are just unable to see the presence of any street connected children in the particular jurisdictions that they work in. Next slide, please. So while working with the street connected children, we have been able to identify some very prominent issues that are related to mother and child health, some of which have been mentioned by Shona. For example, the experiences of violence, like in terms of sexual abuse and violence, which leads to a lot of unplanned, unwanted and early pregnancies. And there is a lot of prevalence of vulnerabilities among the street mothers, for example, anemia, low weight, STI, and history of miscarriages and stillbirth. And due to the lack of documents like legal identity, they have limited access to registration in hospitals or institutional care, because they are not given access to hospital admission. So those children are delivered on the streets. We have seen children being delivered on the streets, which is a high risk in terms of maternal or infant mortality. And as a result of all these issues, the child is born on the streets, and like a cycle, the child does not have any access to birth certificate because they are not born in institutions, which later results in lack of access to all the rest of the services in the life of this child. Next slide, please. So the next two slides will be explained by my colleague Naresh about the 1,000 days approach that we have tested on the street population.
Thank you, Devapriya. And just to continue with what Devapriya has said, we have adopted the first 1,000 days of life approach, which is very universally adopted across various parts in the globe for developing their social policies, even by government while drafting their social schemes and all policies related to the welfare of the mother and child. So when we say 1,000 days of life approach, we actually cover a time period from conceiving to the first to live birth of the child. Second the birthday, and because we consider it, and as it has been also evident from various research work and all, that 80% of the child mental growth and also the physical development depends upon these crucial 1,000 days. And if we address these 1,000 days very critically and make ensure that their health and their nutritional needs are fulfilled, then it will have a lifelong impact on the child's future and also help us to break the malnutrition cycle along with poverty as well. So if you can see the breakdown of this 1,000 days is given till here. Can I can you move to next slide, Shona? Yeah. So when we say the next 1,000 days of life, so we also have a core indicators for addressing this 1,000 days of life, which help us in also implementing the program and also understanding where we are impacting and how we are going to monitor the changes that we are going to bring while doing any kind of program related to this approach. So if you can see these 1,000 indicators starting from ANC and PNC care. So ANC stands for antenatal care and postnatal care. Second, prevention and management of anemia. Third, early initiation of breastfeeding. Fourth, exclusive breastfeeding. Fifth, timely complementary feeding. Sixth, age-appropriate feeding. Seventh, full immunization. Prevention and management of malnutrition being point 8, and 9, 10, 10 being prevention and management of diarrhea along with WASH. So these 10 indicators are very crucial for us. And just to emphasize upon it, we do in terms of our program, which we are monitoring in urban health, addressing the street connected children and the population that we are dealing with, we make sure that these 10 indicators are properly monitored, and we do have a mechanism of collecting the indicators, indicator-wise data through a cohort format, which we keep a track till 2 years, and just to monitor the progress and impact this project will have on the street dwelling population and the beneficiaries that we are trying to reach. Can you come to the next slide? So as we had this approach, so we had this pilot project, we call it 1,000 Days on Street. So we initiated this project not very recently. And as Devapriya has highlighted, before initiating the project, we did some analysis of the challenges, which is already highlighted through our study that we conducted. So based on that, we created a program, a very small program in a pilot self mode. So under this program, we actually have developed certain activities which are based on and which will help us to achieve certain outcomes. So some of the outcomes are like, for example, early registration of pregnancy. Second being ensuring at least 4 antenatal checkups, promoting institutional delivery, access to social security, birth registration, inclusion of nutrition services, and also removing vaccine hesitancy, which is very much high among the street dwelling population. So coming to the last presentation we started, we had from Shona. If you can see, actually the rise more with accessibility. So they are entitled But due to existing stigma and the kind of hesitancy that they have, and the feeling that these children and basically the mothers also feel that if they access these health services, they might be stigmatized or they might be treated very badly and they might not be given the service. So for that reason, they don't go to these institutional services and health checkup for the regular checkup also. And if they don't go, then they might not have a proper health treatment services which are entitled for them. We do have several social schemes and policies drafted for them only. Like in India, we have some policies called National Urban Health Mission. So it also specifically clearly talks about for the urban poor, including street dwelling population as well. But the challenges lies these populations due to the stigma and all, they don't feel like getting access to this, going to this institution and avail those services which are available for them. So we are trying to address this issue. So, and if we make, and through this process, if we address it, then like, for example, institutional delivery, if institutional delivery is ensured, then there is a very easy that they can get an identity of their birth, a birth certificate for their child. And that identity itself gives way for various other kind of entitlement and service accessibility, which are there available for them. So all these kind of points have to be made sure through this early initiation. Apart from that, we do have a mobilizing network of 12 NGOs. So we work on convergence mode also. So we have a network of NGOs who are also working on the similar line. So we meet them and we do clear them our ideas that how we are going to approach if street dwelling population and all children, and how can we help them in doing this part. And similarly, we have other like hand holding support to the frontline health workers. So many of these health workers who are basically the service providers, they are also not properly trained to meet the needs of the street children and street population and all. So we train them and we give them and we and build their capacity and explain them how they can help us in ensuring the service accessibility to these children as well. And also on an advocacy level, we are also trying the inclusion of street mothers into government health MIS. So government usually make a record of their health services, that how much services they have provided to population. But most of the time we find that the street mothers are missing. So we are trying to bring those mothers into the picture and back to the record of the government data so that it can keep a proper recording. And so this whole approach and way of working has helped us in doing, for example, like marking spots where settled populations and children are there. So we have identified the hotspots. These hotspots are identified in the later half of the day, because at night only they come back to the street again, because in the morning they go to different places for their earning purpose. Then, and we have started identifying the mothers who are in their early pregnancy stage, and then we're giving them service accessibility. We're taking them to the nearest healthcare center for the registration and all. Then referral and cohort mechanism based, as I said, we are keeping a data record also of this, that how many mothers have we identified and how many of them are getting the services, and making sure that all these services are properly accessed by them and they are entitled to. And lastly, all those hotspots are, we are trying to get them included in WHO high risk areas. So WHO develops this high risk hotspot areas of their own also. We also try to bring that thing from our research to their notice, that you can also include these area so that the services can be accessible to them. Can I go to next slide? So here we have one case study which we would like to share. I will ask Devopriya to explain in detail about this case study. This will be very good for understanding the context.
Thanks, Naresh. So I will just briefly, because in interest of time, I am aware of the time that we are taking. So this is a very striking case that we came across recently. So we have a very close network of street dwellers, street shoppers, street shopkeepers and stall owners. So one morning, our street workers, they received a call from one of the shop owners on the streets who told us about a mother lying unconscious on the streets with a newborn child. So our street workers immediately reached the place and found a mother lying unconscious who has given birth to the child on the street a few hours back, and the child lying on the side. So Fatima, we took the mother of the child is Fatima, name changed here. So we took her to the hospital with support from the police, mobilized immediately from the nearby police station. And there we got to know that she has given birth to 5 more children in the same manner, and she has cut her own umbilical cord with blade, and that is how she gives birth on the streets, because she does not have legal identity and she does not get admission to hospital. So this is a case which always inspires us, and we think that this is not the way that any human being should be treated like. So all the children, all the mothers should have access to healthcare, antenatal care, institutional delivery, and our purpose is to ensure that all the mothers and children have access to that. Next slide, please. So lastly, the way forward, that this is a very nascent stage that we are working in, and we are very new in trying out strategies for ensuring healthcare of street connected children, because they need to be obviously tailored because of their high vulnerability. And currently the method we are following is case management, but we have to think of sustainable ways in which the healthcare system can be well equipped in order to address the issues faced by street connected population. So in terms of capacity building, we are providing hand-holding support to the local government institutions as well as the healthcare system in order to plan and allocate the resources as well as the service system, so that they can be well equipped to address the issues faced by street connected mothers and children. And in terms of social development programs and the services or resources, we have conducted a citywide mapping in collaboration with our network partners in order to identify the number of street connected children which is not present in any census, and we have been trying to put them in the city map so that the resources can be allocated according to the number of street connected children, the population, so that the resources are well allocated. And in order to strengthen the agency of children and mothers, we've always been promoting children's groups and mothers group being included into institutional mechanisms of the government. In terms of convergence and advocacy, I would request Naresh to explain. Thanks.
So under the convergence mode, as we said that we have already identified the hotspot areas where we have found very street dwelling population residing and all. But these areas are also areas where most of the services are not covered or they don't fall into the jurisdiction of the services. One of the services is immunization. So Government of India under this scheme of routine immunization, national immunization scheme, they provide immunization support for 12 diseases. But and these are free of cost vaccines. They are given to the both pregnant women and children. But it's just that they have to go to the health center and access those services. But most of the time, as I said in the very beginning, this population don't go to the healthcare center first only because of their stigma and the differences that they find. So what we did, we with the government have identified those areas and we have bifurcated those areas which are left uncovered by the government health workers or professionals. So what we do, we have deployed our street champs and street volunteers and all who are helping us in this project. They identify those children, those mother and everyone, and they prepare a list of their names that which we submit them to the nearest health center, whichever is to the nearest to the point, and make sure that these beneficiaries get their due vaccine on time, so that they can be protected from post critical diseases that which impact their life on a very long run. So that is one area that we do in convergence mode with the nearest health center along with the local government administrative body. On the advocacy front, we, as we said from the very beginning, advocacy has been one of the key tools and will remain one of the key tools for addressing the needs of the street children and population. So we are already doing that with our network of NGOs and other government organizations also. We are constantly presenting our work and we are advocating at the policy level so that for the next time, whatever the policy comes or whatever changes come in the policies, those can particularly address the needs of the street chronic population and emphasize on their particular needs. So these kind of advocacies are also going side by side on the policy level to bring about the policy level change. And lastly, as we said, we are in a very nascent stage where we have running this project in a pilot mode. But after the initial and we want to definitely highlight a good model practice which can be replicated in the center stage for both at the national and for global level and for the audience and see with adequate resource. So the limited resource we have to run this pilot project, if we get a good number of resources, support on the local, on the national and global level, then obviously this issue can be addressed across all the Asia Pacific region or for that matter across the globe. And this is the way we are trying to bring it. So bringing best good practices is one of the approach that we are trying to highlight, and we will definitely share that with you all as well. So this is finally for end from our end. Thank you everyone, and we are ready for questions.
Yes, yes, Abby, we must move to questions. Thank you. Thank you everyone for being so patient.
No, thank you for all the information you shared.
It's
brilliant to have such a detailed explanation from your context through to your work with street champions and all the way through to the more specific work with women. It's fantastic. I haven't been able to read the chat, but I've seen that there's lots of people expressing their own experiences and different things. So hopefully people have been able to have a look at that whilst we go through. Maybe there's a way of us sharing that afterwards, because I think there's probably lots of really great experience in there. I think the only question I've seen come up so far was Mindart talking about tips. I wonder if you wanted to come on and explain that question or ask it in person.
Yeah, thanks, Lauren. Happy to do so. I really enjoyed the presentations, including also Shona's research, to which we also participated. The things we've heard, though, to most organizations, I guess, who have been working with street children for a while, much of it is not really new. It is sort of the existing problems that we are all very well aware of. So my main question is, now that we know all these problems, how can we translate that to the frontline work, especially in service delivery organizations? And how can we, for example, if an organization like Amani, if we would like to spend 3-4 hours a month on trying to promote, and what advice would you give us? Yeah, because we are not going to embark on a comprehensive program that CINI has been doing. But if we have only like 3-4 hours a month with frontline do with all this information?
Well, I can't say much about what you should do with that information. I don't think I'm best placed to give that advice. But what I can say about the research is that, yeah, this is really confirming a lot of what we knew either from experience or anecdotally. What we're hoping is that this will be published in an academic journal, which adds some clout for advocacy purposes. When we can say, look, we've done this research systematically, we have this evidence now. So I hope that it can add some evidence that might help from an advocacy perspective that way. From what you should do with it, I think so much is context dependent. I know in Tanzania, for example, we're hearing so much about the issue of health insurance. So it's about, might be something about that you can tackle, but whether you approach it from an advocacy perspective or a direct service provision, it really depends on the makeup of the organization, doesn't it? Maybe Deborah Priya has more useful advice for you.
In terms of the street workers that we have, the introduction to street work method has, like, the training of introduction street work has been very useful, because it actually guides the street workers about the unconditional positive regard and the non-judgmental attitudes and empathy that street workers are needed to practice. And it actually helps them to translate those philosophies into practices. And since those street workers are the ones who directly come in touch with the service providers, we have actually been able to translate those philosophies into trainings that we conduct with the frontline service providers of the government as well. So I think those kinds of training, even if broken into smaller capsules, will be very helpful for 2 to 3 hours of training sessions with frontline workers.
Thank you.
Thank you both for that. Another question's come into the chat, which is quite specific from Tijani, asking if there's any antenatal clinics in India that have mobile delivery points within the different cities, so you can take advantage of those to help mothers and children looking at the way they're mobile themselves and move around a lot. Is that something you're able to use in India?
No, so the deliveries, they are required to be conducted in the hospitals because the hospitals only have the proper equipment. But in some places of India, we are promoting like assisted deliveries by building the capacities of midwives, but that has not been very successful till now. But India is moving towards capacitating the midwives as well, along with the frontline workers.
I would like to add to this. Considering in India, we have a health policy schemes, as I said, National Urban Health Mission. For rural, we have National Rural Health Mission. So for urban area, we have a different health mission altogether. It's very mission. 2013, it has come into picture in India. So as per the administrative structure, the point delivery, where we find ANC checkup, antenatal checkup and care. So they have developed creative. So for the first point is the primary healthcare center, which we call in urban context, urban primary healthcare center, UPSCs. So these are centers where antenatal checkups are provided, but definitely for institutional delivery, you all have, they have to visit the nearest hospital, be it government, and they can deliver there because these urban primary healthcare centers are only enabled to do the antenatal checkup, primary checkups only, not the delivery part. So all kind of deliveries and all have to take place in the hospital only. With more advanced level of doctors and all. But yeah, we do have a network in the way we have service accessibility points. So these urban primary healthcare centers are based on the population. So for our urban administrative structure wise, so based for 50,000 population, we will find one urban primary healthcare center in each location for each any geographical area. So if we have more than that, they will have more than one UPSCs. But they are also placed geographically in those areas which are mostly covered by slums or street dwelling population. So that becomes easy for access for all. So that is the reason we have this kind of structure. And then we have our other tertiary level, we have our all hospital, government colleges, medical colleges, where people go usually for institutional delivery. So these are the structure there. And right now there is an issue, but yeah, it has improved a lot post-COVID era, because most of the vaccines of COVID are given from these centers only. So people are not much aware about these centers and the services which you provide from these centers. So they are accessing at all.
Thank you, Naresh. Just to say, I'm aware we're at time. There's two more questions that I'd like to be able to put to our speakers if that's possible. But if people need to drop off, then that's no problem. We will just ask these two further ones. I can see Shona has responded in the chat to the first question around the demographics of children. So that's great. So a final question for CINI then is just Pia is interested to know if you've been able to measure any changes in health-seeking behaviour as a result of peer-to-peer communications using your street champions or child advocates.
Yes, absolutely. So we started off with 450 children, 450 street connected children, and now it has increased to more than 1,400 street connected children who have been able to access not just health services, but legal aid, as well as like drop-in centers, social security schemes, and other services as well. And that is all because of the street workers and the street champions who have been able to be there with the street connected children and like link the street connected children with the service providers, so that there is more increased accessibility to services. So yes, there has been a marked increase in not just healthcare, but in education, protection, health, and nutrition services as well, because of the continued efforts and advocacy of the street champions.
Thank you so much, Debapriya. That's a brilliant answer. So at this point, we will close. I know there's been loads of conversation in the chat, which is brilliant to see. So hopefully, again, this is a conversation we can continue going forward. Firstly, I want to say a huge thank you to Shona, Debapriya and Naresh for your fantastic presentations. I'm sure everyone hugely appreciates being able to hear those today and all the things that you've been able to share. I'm just going to share my screen for a second longer to show you the the final slide, which will tell us about what's coming next, if I can get to it. So this afternoon, we have a meeting on reframing our approach to use of children's images, which should be fantastic in thinking about the way that we use those images safely and appropriately, but being able to still show what we do within our work. So we're really excited about that one, and we'll have a number of presenters again taking us through that session. Following that, later in the week, tomorrow we have sessions on enabling access to education, which again we have great practitioners speaking in that one. We have sessions on upholding street-connected children's civil rights and freedoms, and also around working with the police on Friday. So again, please register for any of those sessions, or if you're interested but can't make them, if you register, you'll be able to receive the recording. So hopefully we'll be able to see some of you there. Thank you again for all of your time this morning, and hopefully we'll see some of you at the session this afternoon. Thanks, everyone.
Thanks, everyone.
Thank you. Thanks a lot.
Thank you.
Thank you.
Thank you.
Thanks, everyone.